Hello, everyone. We're going to put a little bit more meat on the bones, if you will, for this orthodontics unit. And this PowerPoint is going to show a lot of the pictures and also give you a little better idea of some of the things that we talked about in our first lecture. So hold on tight. Here we go. So when we talk about malocclusion, there were some references to normal class 1, class 2, and class 3 occlusion in the last lecture. So we're going to give you some actual images for what this type of occlusion looks like. So overjet is part of a malocclusion where the maxillary anterior teeth are quite far out horizontally from the mandibular anterior teeth, as you see in this photograph. And then in the drawing of the young person with this type of issue of overjet, that's kind of what their profile looks like. Their upper lip sticks out a bit. Sometimes their maxillary teeth sit on their lower lip because of how far out their teeth are from their mandibular anterior teeth. Here's another type of malocclusion called overbite, and this is where the maxillary teeth overlap the mandibular teeth. The image on the left shows a 100% overbite where those maxillary teeth completely cover the mandibular teeth. The other photograph on the right side shows more like maybe a 60% overbite, where in textbook cases we want the maxillary teeth to cover about 50% of the mandibular teeth. Here's a case of crowding and a couple of different types of crowding. So the image on the left, once again, is a case of severe crowding. So much crowding, in fact, that the cuspids are not able to erupt properly because we have looks like a lateral that's lingual, cuspid is buccal, and then we have either retained baby tooth or a very, very crowded out bicuspid, and that looks like it's bilateral. On this case, there is no space, but for some reason, this cuspid is not able to fall into the proper spot. Perhaps this would be a case, again, of tooth being prematurely lost in the deciduous dentition. Not exactly sure, but there's something that's preventing that tooth from falling into its proper spot of occlusion. And this is the opposite problem where the patient has extra space. So there are spaces between the teeth. There is no contact between the teeth. The teeth are able to kind of just wander around mesally to distally. And this would be something that the Invisalign company would show up on their treatment plan. This case looks like someone was probably sucking on a finger or a thumb and dislodged these teeth, but there is definitely still space between the midline here in this case. This page looks at open bite. So our posterior teeth, if you notice, are in contact on both of these images, but the anterior teeth is clearly not in contact. And those anterior teeth will not be in contact because of some type of obstruction that molded the maxilla to be in that position with the bone. So typically this is what is seen for people who suck their thumb or who suck their fingers. These two cases are instances of crossbite. So when we have crossbite, that means that the mandibular teeth, as we see here and here, are on the outside of the arch. And as you recall, normal occlusion has the mandibular teeth on the inside so that one doesn't bite their cheek. So in this case, right here, the entire left side of this patient is in crossbite. On this patient, we have, it looks like bilateral type of crossbite because the lower cuspid up here is on the outside and these posterior teeth over here are on the outside of the arch. So this case is going to require a little bit extra treatment to get that to be moved around into a normal position. This type of malocclusion is called edge-to-edge, and this is referring to the incisal edges. So we have the incisal edges coming in direct contact maxillary-mandibular. There is no overbite at all in someone with edge-to-edge. And if you see something like this, where it's kind of like a lock and key almost, where you can see exactly where those teeth come together. Same thing right here. So they come together, and the incisal edges of the maxillary teeth is where that plane of occlusion occurs. Here's kind of a unique problem, not problem, but a condition where we call it end-to-end biting, or occlusion, where the cusp tips, the buccal cusps of the maxillary teeth, are in direct contact with the buccal cusps of the mandibular teeth rather than them kind of overlapping one another. So that is a unique, not very common occlusion to see, but it does happen occasionally. Edge to edge is anterior, end to end is in the posterior. Here is a condition that we call underjet. So this is where we are in a class 3 malocclusion. The lower jaw is out in front of the maxillary jaw. So that means the mandibular teeth are going to cover the maxillary teeth in the anterior. Both of these cases have it. This person looks like a little younger person. I can tell from the mamelon and things that are still present on the teeth. And then this person has been in this type of occlusion for a while. Here we have a diastema that is just simply known as a space between 8 and 9. There can be spaces elsewhere, but specifically a space between 8 and 9 is known as a diastema. Obviously, this one is a little bit more severe or visible. This one still has a diastema, just not quite as much room between. And here is why we recommend people get their malocclusion fixed or looked at and treated, because we don't want the teeth to end up like this. This person probably was possibly a class 3. They have a crossbite, and then that turned into maybe an edge-to-edge bite, where these anterior teeth just continue to become worn and worn and worn, and now we have pockets of the teeth fitting into each other. So this is a very severe case, and this would require a complete full mouth rehabilitation to get this treated. This person also has some malocclusion, and not quite as severe as the other case, but there's definitely a lot of wear on these incisors and a flattening of the cusps. So if a person would have had some orthodontic treatment to combat these things, they would be in a completely different stage of occlusion at this point in their life. Another reason we want to treat orthodontic cases is because it does wear on the temporomandibular joint and cause dysfunction. So we know from anatomy class that the TMJ should be nice and rounded all through that condyle. And when it is worn, it becomes sharp, it becomes pointy, it becomes flattened. And when that happens, it does not allow that little meniscus, that disc, to move freely between the joint and the skull. So it can be pushed forward and lock, especially if that joint is pointy right here. If it malpositions this way, it's going to stay here and prevent that joint from moving. It also contributes to crepitus, which is that clicking and popping and grinding that sounds in the patient's joint. So all of those things can be exacerbated by having malocclusion. Now, sometimes patients will complain that their malocclusion or their TMJ got worse after some types of orthodontic treatment, and that typically is temporary, but some people do say that. So we always have to keep in mind that the TMJ is very fragile, very fluid. joint in the body and needs to be taken very well care of. So we can manage some of these processes by doing some removable functional appliances to correct the muscle and to then begin to move the bone to move the teeth. So here is an example of a functional appliance that's removable called a twin block. And they call it a twin block because, guess why? There is a block on the maxillary and a block on the lower. And when the patient puts their teeth together, they have to manipulate and move their jaw so that this block comes into this orientation. So when this happens, it changes the musculature, and it also helps to change the eruption of the teeth to probably open the bite a little bit to allow for that cross bite to be corrected and so forth. This is another type of removable appliance. These expanders can be fixed and removable. So these are a couple of examples of the removable type. So we see that they look a lot like retainers that you're probably pretty familiar with seeing, but this is a mandibular expander, and this is a maxillary expander. So both of these appliances have a little screw in the middle to begin the widening of the arch. So that is exactly their purpose, is to widen the arch and to make it more aesthetic and functional. And you see on this one very well this arrow, so this little key that is given to the patient. The patient is instructed every day or 2 or 3 to move that screw however many rotations is prescribed by the dentist or orthodontist in the direction of the screw. And the patient needs to wear this all the time, even when they're eating usually, and then they take it out just to clean their teeth. Otherwise, that appliance is on their teeth and moving that palate or the jaw. Here is a fixed example of an expander, and this one goes on the lower as well. So these bands would be cemented on the teeth, and the patient would wear this all the time. This would be for a person who perhaps wasn't very compliant, or someone who we just think would be better served to have the expander cemented on their teeth versus allowing them to take it in and out. And again, you can see very easily the direction of the arrow is supposed to go down, so they would insert the key, either this style or this style, into that little hole right there, and they would move the key in the direction of that arrow. Here are some other types of fixed appliances, and these are both examples of expanders. This one is an expander. You can see here where kind of the palatal midline would be where that suture fracture would happen when that first turn of the screws would happen. So we again see the bands that would be cemented over the molars and be cemented in place, and the patient would not be able to take this out. This case I thought was very interesting in that it is cemented in the patient's mouth, but this is how much room was created when this appliance was used. So hopefully this patient, now that we see this beautiful rounded arch of their teeth, they are probably about ready to have this appliance removed from their mouth. Another type of comprehensive appliance, this one is known as a Herbst appliance. I've never had a Herbst appliance. None of my kids have had Herbst appliances, but there were plenty of times when I was working as a dental assistant and had to do a coronal polish around a Herbst appliance. So this is the profile of the pre-treatment and then post-treatment of the Herbst, and it's really a kind of a motional appliance that is going to help with, again, musculature and with the bone of the patient's teeth. So it adjoins the maxilla and the mandible. So the first 2 pictures show the patient in the right buccal, and then the frontal picture, and then C and D show the palate and the mandibular arch with this appliance in place.